Hello, I'm Dr. Jennifer Brown, and on behalf of CME Outfitters, I would like to welcome you to today's educational activity entitled A Global Spotlight on CLL, Shifting Strategies and Optimizing Outcomes. Today's program is supported by an educational grant from Merck. Now, let me introduce the faculty. We have Dr. Paolo Ghia, Professor of Medical Oncology, Università Vita Salute San Raffaele, and Director of the Strategic Research Program on CLL, as well as Head of the B-cell neoplasia unit at Ospedale San Raffaele in Milano, Italy. I'm Jennifer Brown, MD, PhD, Director of the CLL Center and Institute Physician at Dana-Farber Cancer Institute, and the Worthington and Margaret Collette Professor of Medicine in the field of hematologic oncology at Harvard Medical School in Boston, Massachusetts. And we're joined also by Dr. Tom Munir, MBBS, PhD, consultant hematologist at the Leeds Teaching Hospitals NHS Trust in Leeds in the United Kingdom.
Hi.
Paolo, I'll continue with the learning objectives then. We'll be assessing testing strategies that may inform clinical decision-making in the management of CLL, utilize updated guidelines and evidence supporting the integration of targeted agent classes in CLL as single agents or as part of combination regimens, including continuous therapy, fixed duration options, and novel combinatorial regimens. And we should be able to evaluate recent clinical evidence on current and emerging therapeutic approaches that have been evaluated for the treatment of patients with relapsed refractory CLL and/or therapeutic intolerance. We'll continue with just a brief introductory slide on the global burden of CLL, which is illustrated here. We know that particularly in Europe, North America, rates of CLL are quite high, and that CLL has a much higher prevalence than incidence because fortunately patients do live a long time. And so we have substantial populations of patients living with CLL over extended periods who need a range of different treatments. So our first question, when do you use biomarker testing for patients with CLL, SLL? I do not use biomarker testing. I do it only at initial diagnosis, only at first progression, at initial diagnosis and first progression, or prior to any new treatment. So if everybody can answer that question, get us started. Okay, so 27% of people are not using biomarker testing at all, 20% at initial diagnosis, 13% at first progression, 33% at initial diagnosis and first progression, and then 7% prior to any new treatment. So, you know, that's a somewhat interesting result. I do it at initial diagnosis, first progression, and prior to any new treatment, especially because we do know over time sometimes there can be clonal evolution to higher risk markers. Tal, did you want to comment on your approach here?
So, yeah, I think primarily similar to your approach. I think in terms of initial diagnosis, the most useful test I find is IGH3 mutation test because that we need to do only once. But in terms of the other markers, it's very much a discussion with the patient as well, what they want to know in terms of the prognostic impact of the biomarkers. And if they do want to know everything, then I do that. But then at progression, definitely. And I think as we'll discuss later, I think it becomes important in terms of the era of targeted drugs that we do the biomarkers at progression so that will help us to inform how best to choose the therapy for our patients. So yes, I agree with all of that.
Right. It's a good point, though, that IGHV is stable over the entire disease course. So once done, you don't have to do it again, in contrast to karyotype, FISH, and mutational analysis, all of which can evolve. Now, we know that biomarker testing is not done as widely as it should be. These are some data from the United States, where, in fact, more than half of patients did not receive any biomarker testing at all. And in particular, when we're looking at the identification of patients with P53 aberrancies, such as deletion 17p or TP53, this is very important because those patients should not ever receive chemoimmunotherapy or chemotherapy anymore. And many of the patients were not identified so that they did actually receive that inappropriate therapy. Okay, now we have another case, a 62-year-old patient who presents with a leukocyte count of approximately 120,000, 80% of which is lymphocytes, hemoglobin level of 8.5, and platelet count of 85. Immunophenotyping confirms that he has CLL, which carries deletion 17p. Which of the following is the best choice of therapy for your patient with newly diagnosed CLL? And the choices are FCR, BR, continuous BTKI monotherapy, venetoclax obinutuzumab, venetoclax ibrutinib, or I'm not sure. So go ahead and vote there.